I'm Joe Markenson, and I'm here to discuss with you comorbidities. Specifically, we're going to limit ourselves to comorbidities, cardiovascular comorbidities in psoriatic arthritis. Now, these are the cardiovascular comorbidities that have been identified in psoriatic arthritis, and they're listed here for you, and they include atherosclerosis, congestive heart failure, peripheral vascular disease, cerebral vascular disease, ischemic heart disease, type 2 diabetes, hyperlipidemia, and hypertension. Looking specifically at psoriatic arthritis, though, we have good data, remember, from rheumatoid arthritis and systemic lupus erythematosus, that comorbidities track with activity of disease, possibly influenced by therapy, but they are independent of the traditional risk factors. Does that occur in the spondyloarthropathies? Well, let's look at psoriatic arthritis first. And in this nice study, they looked at the risk of myocardial infarction in patients with severe psoriasis and mild psoriasis against controls. And there's no question that if you look at the particular data here, starting with the younger patient, there is an increased risk of myocardial infarction independent of the traditional risk factors in psoriatic arthritis. Now let's look a little bit more at maybe what the mechanism of this might be. A nice article by Bonecki was published recently which started to address maybe mechanistic problems. Now, metabolic syndrome turns out to be the most severe comorbidity that people see in both psoriasis and psoriatic arthritis. And obesity is one feature of it. So if you have psoriasis, it's postulated, and are obese and possibly smoke, this leads to increased systemic inflammation, which leads to insulin resistance. Now remember what this means. You change insulin from pro or anti-arthrogenic type of properties to pro-arthrogenic, and that allows more endothelial dysfunction, increased atherosclerosis, and eventually will end up in a myocardial infarction. There's no question that patients with psoriasis have at least 5 times the increased risk for diabetes and double the risk for myocardial infarctions. Now, let's look a little bit wider at some of the other diseases, RA, PSA, and AS. And in this particular very nice study, which looked at 28,000 RA patients and 3,000 psoriasis patients and about 1,800 patients with spondylitis against age and sex-matched controls, looking at the various cardiovascular events that might occur. And they're listed on the bottom of this for you and include the ones I've mentioned before. You can see that it didn't matter what disease you had, either RA, PSA, or ankylosing spondylitis, your ability or your risk, let's put it, for having increased events was elevated above normal controls, with the exception maybe of atherosclerosis when looked at as a general entity. So what are the points that we're trying to discuss here? Comorbidities do exist in RA patients and are independent of other risk factors such as hypertension, hyperlipidemia, and smoking. Comorbidities in patients with rheumatoid arthritis appear to track and correlate with activity of disease, and maybe they even diminish with treatment. Similar comorbidities we're finding now also exist in the spondyloarthropathies. And so there's some question about whether there's good evidence for this and are they independent of other risk factors, but I've shown you some studies which would say yes. I'll take some questions from the audience.
So Joe, I will go to the last point you made, and that's something that I think we have come to accept in rheumatoid arthritis and see, and I guess the question in psoriatic arthritis and other spondyloarthropathies is going to be, how tight do you think that link is between the disease activity and disease severity and the risk of these comorbidities, which would obviously speak to how worried we have to be about these folks?
Well, I think you're seeing a pattern emerge here of systemic inflammation, and I think the evidence that has been published actually several years ago in systemic lupus and RA is very solid. I think we're beginning in some smaller studies now, we need more numbers, to demonstrate the same thing that can occur in spondyloarthropathy, and I include in that psoriatic arthritis and ankylosing spondylitis. But the evidence is coming. It's not as great as it is with the other illnesses, but I think it's showing us the same pattern.
Is there good evidence that treatment which reduces the activity of disease also decreases the severity, incidence, or prevalence of comorbidities?
I think there is weak evidence. I think there's strong evidence, as I said, in the other illnesses, and we'd like to think of that. Now, there was a recent paper at our last ACR meeting looking at ankylosing spondylitis and saying that, only if you had increased activity of disease did it correlate. In other words, treatment diminished a little bit the comorbidities. And so I think we need more evidence. We don't have it all yet.
Joe, what do you think about our role as rheumatologists to be involved in managing these comorbid issues? I know that in our practice, it really depends, for example, on how diligent the primary care physician is that the patient is working with and whether they're looking to us for primary care in this area or whether we should be hands-off and leave it to the primary care doc or the cardiologist.
I'm very passionate about this. I like to take care of the whole patient. And I know that may step on some toes now and then, but I think if the bottom line is, as rheumatologists, we have to be proactive in recognizing this as a problem. We have to be proactive. Whether we treat it or not, we could argue about, but we better shift our focus and recognize this, recognize the risk factors, evaluate them in the patients, and suggest to the patient either that we're going to treat it or we're going to talk to their primary care doctors. But if we don't bring it up, then we're really at fault.